African Ascent continues to benefit, as I have repeatedly attempted to say to my audience, from the generous support and presence of some of my stellar colleagues who come in the form of composers, writers, producers, activists, and so on. Upon their first appearance, African Ascent has always taken the privilege to invite them again and again, and some of them actually have managed to become regular contributors to African Ascent. My guest tonight, Professor George Eastman from Berklee College of Music, wears two hats, to put it mildly. He is both a philosopher who belongs to a particular strand in the history of modern philosophy that we call analytic philosophy, the chief task of which, or the focus of which, is a commitment to clarity, to what the philosophers themselves call linguistic clarification. He, as my guests will shortly notice, brings that analytic training, namely the respect for words, the respect for their uses, and vigilance and attention to the particular ways in which words are used, as he will philosophize with us tonight. The theme of his presence tonight, his talk tonight, his conversation tonight, will be the value of psychotherapy. And for those of you who do not know, the relationship between philosophy and psychology has been quite intimate. In fact, we could easily describe them as cousins. Philosophy, as most people know it, to some did not necessarily originate in the European landscape, but they push its home back to ancient Egypt, in which it was practiced by Egyptian priests, to which then later famous Greek thinkers, Pythagoras, Socrates, and Plato himself, and Aristotle, and many others confess in their writings that they have actually benefited from the teachings and wisdoms of the priests of ancient Egypt. Philosophy then began really as an attempt that thought to make itself relevant, to help human beings to take care of themselves, to attend to the internal conditions of their souls. In the hands of Plato, for example, Plato advises us that we need to manage this otherwise chaotic relationship that is inside us, between the competitions that take place among reason, desire, and spiritedness. Philosophy then, not necessarily in the hands of Plato only, but most particularly in the hands of the Stoics, takes a different kind of discipline, a different kind of turn. It attempts to advise and to help human beings to know themselves, to know the universe in which they live, and to seek to know the passions, desires, and needs of their neighbors. The philosophy then takes and evolves even more, and it makes an attempt to benefit from the scientific tradition, most notably in the hands of the great Freud, who turned his attention to help the human sufferers, all those patients who came to him to be assessed, to be helped, to be taken care of, and to be advised. Professor George Eastman participates in these two traditions. In addition, he's also a practicing Buddhist, a meditator of the human soul. And additionally, he's also interested in Asian philosophy. And he combines then a wide array of the facets of philosophy, namely its classical roots, and also its modern garb. Additionally, I am very proud to share with my audience that he's also a practicing psychotherapist, a psychoanalyst, however he defines himself. He's a consultant. He serves in some powerful boards of public and private schools. He's a founder of a private school himself, about which I will ask him to talk, should it turn out to be relevant. And in addition, he's an acclaimed, highly respected professor of philosophy / psychology at Berklee College of Music, trained at some of the major universities in the world, Harvard itself, New York, and so on. So you can imagine, considering how long this introduction has been, that I think very highly of him. And in that, I'm honored to have a 50 minutes long conversation with him on the interface between philosophy and psychotherapy, but with a particular focus on psychotherapy itself. Welcome to Afghan Ascent.
Thank you. Thank you.
So where should we begin? I think, if you concur, we should begin with a discussion of what psychotherapy is. What is it exactly?
Mm-hmm. All right. What is psychotherapy? It's it's a little bit difficult to talk if one hasn't been in psychotherapy. It's psychotherapy is a way of helping human beings to get in touch with parts of themselves that are troubling them, parts of themselves that lead them to do things which they may not want to do, say compulsions, for example, or a person who has a bipolar condition who fluctuates between, say, depression and a manic or highly excitable condition. That's very difficult to be in that frame of mind where your feelings are jumping all over. So psychotherapy names a very broad range of ways to try to deal with thought problems, behavioral problems, and problems of emotion. So behavior, thinking, and emotion. All of those come under what's called mental illness or mental health problems. So when we talk about psychotherapy, we're talking about trying to name these different kinds of problems or conditions that bother a person. And we're talking about trying to diagnose these conditions, which means trying to identify what the characteristics of the conditions are. And psychotherapy also has to do with how you treat these conditions so as to help the person to overcome the suffering, the torment, extreme suffering, or to overcome the disabilities that these conditions are causing in their life. So we're talking about real human issues, real human problems that are very disabling to people. Psychotherapy has to be ideally voluntary. Is you can't direct somebody to go and have psychotherapy. Somebody has to reach the point of suffering sufficiently where they don't want to have this condition anymore, so they will seek out help. In my case, I'm a licensed clinical psychologist. I do basically everything that a psychiatrist does, but I do not prescribe medication. I'm not licensed to prescribe medication. So typically a person will call me, very often a person who has heard from a patient of mine about me will call me and say, I would like to set up an appointment. So we will set up an appointment and the person will come to my office. I have an office in Cambridge, very close to Harvard Square. And now there's a question of, well, how do I approach this? What is my attitude as a psychologist? By the way, the word psychotherapist is like an umbrella term. Mm-hmm. And under psychotherapist could be a psychiatric social worker, a a mental health counselor, which is a type of licensing which Massachusetts has. It could be a family counselor or therapist, could be a psychiatrist, could be a pastoral counselor, somebody trained in divinity school, you know, to work with people's emotional problems, and a clinical psychologist such as myself. So the word psychotherapy, there could be many. In fact, to call yourself a psychotherapist, you don't need to be licensed. You can put out a shingle and say, I'm a psychotherapist. But to say you're a psychologist, you have to be licensed. To say you're a psychiatrist, to say you're a mental health worker, to say you're a psychiatric social worker, those all require a licensing procedure with licensing boards, and you have to take an exam and renew your license periodically. So the person comes, and my attitude towards people who come to me is that it's a kind of Buddhist attitude of no mind. I don't know anything about them, even if I've heard things about them, which does happen. I approach it with as open a mind as possible, and from the time that I see them in the waiting room until they appear before me, I'm forming impressions, but I'm not forming judgments. Impressions are not judgments. I'm just taking in the way that they're sitting. If I look in the waiting room and the person is sitting like this, you know, and then they get up, you know, and you know, they obviously are depressed, or something is disturbing them. And so I'm observing. I'm being a very, very careful observer, a non-judgmental observer. And I have for every one of my patients, I have a little notebook, a little spiral notebook, and if I don't take notes during the session, and usually for the first few sessions I don't take notes, but afterwards I always do. And I try to capture these impressions. I listen carefully to what they say. If there are certain important phrases that they're using, such as I hate my father, or I hate my mother, or I used to cut myself. You know, these important information, I might in fact write things like that down. Usually I see a person, I have an agreement with them in the first session. I say, let's meet 4 times, and in the 4th session I will share with you my impressions. I'll share these impressions with you. And usually at the 4th or sometimes the 6th session, I will share with them what I see as my impression of what the issues are that they're bringing. And the usual length of time that people work with me is about 4.5 years. Now, there are many different approaches to psychotherapy, and there's a movement increasingly to try to shorten psychotherapy and to make claims that this can validly be done. And the insurance companies are very, very happy with shortening insurance, shortening treatment, because they don't want to reimburse, they don't want to pay for treatment. But the fact is, if anyone brings a truly severe and even crippling emotional, behavioral, or thought problem, that's about what it takes. It takes about 4 years of very steady work, meeting at least once a week, sometimes twice a week. What happens between me and the patient is an alliance develops, an alliance. It's a clinical alliance. It's not a personal or intimate alliance, and it should not be that. One of the things that a psychotherapist, a good psychotherapist, a psychologist needs to develop is what I call empathic detachment. Empathic detachment. And empathy is not sympathy.
What's the difference?
Sympathy is when you intellectually understand the person's suffering, but you don't really feel it yourself.
I see.
Empathy is when you cross over and you feel the other person's suffering. You feel it. Sometimes I will cry in a session. I worked with a young woman for 3 years, and she was from not Serbia, but one of the countries which formerly made up Yugoslavia.
Mm-hmm.
And the particular grouping that she came from was oppressed by the Serbs.
I see.
And she had an experience as she grew up, she and her 2 sisters, of the Serbian soldiers taking them and repeatedly raping them. And I could not stand. This was in about the 2nd or 3rd meeting. There was such suffering on her part, and I felt it so strongly that I cried. I cried with her. But there has to be a detachment.
I see.
That is, you have to be separate. You can't help a person if you merge with them. You have to keep yourself separate. So maintaining this separateness with the intense kind of empathic connection with the person, that's very central. So I'm feeling what the person is feeling, but I'm remaining detached in order to remain objective, in order to try to gain a detached type of understanding of their condition. Sometimes people who enter the study of psychotherapy, psychology, psychiatry can't do it because they're too empathic.
I see.
And they cannot achieve the detachment component of empathy.
Now, I believe that psychologists, some of them at least, such as Freud himself, take great pride in having been psychoanalyzed first before they could assume the task of.
But some are.
Some of them. Have you been psychoanalyzed?
Yes, yes. That raises the question of the therapist's own mental health, and I certainly moved from philosophy, which I think you mentioned. I have a doctorate in philosophy, and I taught philosophy for about 15 years. And as I taught it, I progressively began to say, you know, a lot of this philosophy is actually psychology. Mm-hmm. And it was by reading particularly Kierkegaard that I first began to turn inward in a more psychological sense. And part of my leaving philosophy, I was a tenured professor in philosophy, but I left that and I went back to school in my 40s to New York University and got a doctorate in clinical psychology. And really the impetus for that was encountering issues in philosophy which couldn't really be resolved philosophically. I had to move into another conceptual domain, into psychology. And it's important to note that there weren't any separate psychology departments in schools until Hull was a psychologist in Worcester at Clark University. Mm-hmm. He established the first separate department of psychology. Prior to that, psychology and philosophy were the same department. They were not separate. And if you read so-called psychology textbooks at the turn of the century, they all deal with theory of mind, and they deal with philosophical theories of perception that go back to Hume and to Locke. They're not experimentally based. It took Wundt, who was a German early psychologist, to develop the first experimental approach to psychology, which eventually were brought into the departments of psychology. But to get back to analysis, so psychologists And no study has ever been done of this, but my impression is that psychologists enter the field of psychology because of their own inner turmoil and their own unresolved problems. That was certainly true in my case. I'm not going to get into the details about my own background. That's not really what we're focusing on. But I came out of a home that was deeply disturbed. My father was a disturbed person. My mother died when I was less than 2 years old. So in my family, 6 of us, my rather pathological father really was a dominant figure. So I had a lot to overcome. Kierkegaard was influential because he helped me to feel that I had a right to explore myself, that was a right, and every human being has that right not to accept who others think they are or who they might believe themselves to be, quite mistakenly. But I had a right to probe deeply into myself, and this is a very important part of Kierkegaard. Was, of course, a deeply religious person, but he was very much in that Protestant reformist tradition. He was in that Danish reformist tradition, religious tradition, which says that God has given you the right to carve out your own destiny and to find out who you really are. I was influenced by that and by other psychological readings, so that I entered therapy. And then when I went to NYU, and I remained after getting the degree there and practiced in Manhattan for 8 years. And during 4 of those years, I was in an intensive analysis, in a psychoanalysis.
4 years.
4 times a week for 4 years.
Incredible.
And a lot of that work was done on the couch, lying on the couch, free associating. Psychoanalysis, I'm sure many of your viewers will know, it was a technique of treatment developed by Sigmund Freud. And his main writings were in the 1880s, and he died in, I think, 1921 or 22. He fled the Nazis and went to England. And Freud was a medical doctor, but he didn't like blood, and he didn't like medical treatment. So he turned to, although there wasn't a name for it then, but he turned to psychiatry. And there was a famous case that came to him, and he wrote a book about it. The book is called The Story of Anna O, and it's the first of his book before he really developed his complete theory. And by the way, psychoanalysis is a theory. It's not a fact, it's a theory. And so Anna O was a woman who came to him with her right arm paralyzed. Said, "Doctor, I cannot move my right arm." So Freud did an analysis of her, clinical analysis, could find nothing neurologically wrong with her. So he said, well, something must be, things cannot exist without a cause, so there must be some cause to this. So he had her sit down, and then it was clear she was very emotionally disturbed, so he had her lie down. Seeing that Freud was very shy, he sat out of eyesight of her. And she just began to talk, and she talked about her father, whom she hated. But she would visit her father every day, and her father was lying down, and the daughter was sitting at the head of the bed, and on top of a dresser of drawers was medication for him. He had a very, very weak heart. And he began to have an attack, and he said to her, to medicine. And all she had to do was to reach up with her right hand and then give it was glycerin, which gives a kickstart to the heart. She didn't give him the liquid glycerin. He died. And when she got up, her arm was paralyzed. Now this was a very early instance of taking a powerful, disturbing emotion and getting it translated into some physical disturbance. And so he had her talk about it. And eventually, and so this came to be called the talking cure.
I see.
So eventually, I think it took only about 2.5 or 3 months, and she felt trusting and comfortable with him, and she finally admitted that that's what she had done, that I did not give him the medicine. And within a matter of weeks, her arm returned to normal. Once she no longer had that hidden and repressed feeling of intense guilt and shame, probably also, she was able to let that go, and then she was able to let go of the physical symptom, which was the counterpart of the emotional trauma.
Incredible. And now, this leads me to think about the following question. What are some of the most challenging interactions with patients that you have undertaken, which, without giving names, you'd like to share with the audience?
Well,
stated differently, what are some of poignant psychological problems which you would say philosophy in its classical form could not have solved, which psychology solved in your hands?
Well, I'll answer that. I want to come back, though, to the therapist being in therapy, him or herself.
Please do.
I consider that to be a sine qua non, an absolutely essential part of the training.
Okay.
And I particularly respect programs of training for psychologists that require that the psychologist needs to be in therapy. Now, that's the routine of a psychoanalytic training program. You cannot go through a psychoanalytic training program without being in psychoanalysis.
Which is a version of practicing Socrates' advice at the Delphi oracle, that one must examine himself.
Yes, yeah. And and it's a surprising number of psychologists that I know of who have not themselves been in therapy. And I would value the work that they do much less than a person who has really worked. I have been in therapy a total of 22 years.
In therapy?
In therapy. I am currently in therapy. Now, not because I'm crazy, others might have different opinions, and not because I'm working on any disabling issue. What I'm doing is I'm refining myself. I'm sharpening myself. Because our personalities are never finished. We never finish growing. And so for me, therapy now is a process of sort of taking the gem, if I may say that, and polishing it.
I see.
Polishing myself, finishing off rough spots, probing at more depth into parts of the psyche. Because, as a matter of fact, we human beings are many, many layered. We don't have one layer. We are not three-dimensional. We're many-layered human beings. So when a person, to get to your question, when a person comes to me, I know that I am looking at a many, many-layered creation, a many-layered person who has evolved through many, many life experiences. The people that I see generally range in age from 25 to about 60. Most are in that range. I have one 13-year-old boy patient. I've been seeing him for 7 years.
7
years. He's
years.
from Haiti and is a brilliant boy. We play, some of our session is taken up with playing chess. I'm a fairly good chess player, and he's able to beat me at games. So very, very bright. And I have had to intercede at school because he's an example of a very, very bright black boy in this white society and in predominantly white schools with white teachers. And he's highly intelligent, so he speaks up. So if the teacher says, why did you do that? He says, well, I didn't do that. You know, oh, you were being sassy. You know, you're talking up to me. And he will correct the teacher. He'd say, oh, excuse me, I think that was 1066, not 1022. So not this isn't happening now, but early on I would have to go and talk to some of his teachers, and he spent quite a bit of time in the office because he spoke up.
I see.
You know, it's a clear case of racial profiling.
Incredible.
So I see this young man and his mother, and I spend most of the session with him, but I also have his mother because it's a single mother family, and there really isn't any father in the picture. And so there I have that 13-year-old, and I believe the oldest patient I have right now is 71.
71.
A former lawyer who is a severe alcoholic, a woman lawyer. So these many layered human beings present, you name it, they present whatever human problem could possibly exist. They present, if I were to try to sort of classify the problems, identity is a very big problem. You know, people can reach 50, 60, and older, not really know who they are. And and with a 13-year-old boy or with adolescents or people in their 20s, you'd expect, you know, that the personality is not shaped, the personhood is not fully realized. But one can be considerably older and one's personhood has not been realized. One is still sort of floating around, being indecisive. Who am I? What am I? What are my values? What do I believe? What's really important to me? So those kinds of fundamental questions, which are definitely philosophical type
questions, yes.
questions, those always enter in. But only with a few people do I get a chance to talk about them from a philosophical perspective. Most people are not familiar with a philosophical terminology. So a philosophical dialogue. So it has, you know, so I have to deal with those issues, which are certainly philosophical issues from a clinical point of view. And but I have people. I have one lovely young woman. She's 31 and she's completing a doctorate at Harvard. I don't want to say what the field is, but she is so curious and so curious about everything. And so we in my therapy with her, the line between her identity and understanding herself and understanding these other philosophical issues, it's sort of one. It's not really a line. So with her, I can talk about theories of mind, let's say. So, well, what's the difference between the brain and the mind? And what is the why do I feel certain ways? What is an emotion? You know, you could get back to James Lang's early theory of an emotion and talk about modern conceptions and the advances in neuroscience in terms of understanding emotion. So we can get into those kinds of issues with her and occasionally with other people. But generally, this raises the question, I'm not doing this therapy to meet my needs. Okay, I get my needs met appropriately and sufficiently in my private life. So I don't need to act out trying to meet my needs through my work with patients. There's Hippocrates has a lot of writing, and this is a part. This is a translation from this. This is a Hippocratic oath. Now, usually, when people think of the Hippocratic oath, you think do no harm. But this is actually what Hippocrates said. And
Okay.
by the way, we're talking about the 5th century BC in Athens. The Hippocratic oath: into whatever house you shall enter, to whatever house. In other words, there's no class distinction. If it's a slave or if it's the wealthy, into whatever house you enter, your services shall be for the good of the sick to the utmost of your power. Not to your good, but to the good of the sick. You will exercise your art solely for the cure of your patients, and you will give no drugs, perform no operation that will cause harm. Now that gets reduced to cause no harm, but there's a lot more. There's a whole philosophy behind it of helping. And what Hippocrates was talking about, to use a Greek word, was therapeutikos, which is the Greek word for therapy. And this is the translated definition of therapeutikos, looking after someone. So we're talking about psychotherapy.
Yes, correct.
So, but the concept of therapeutic, looking after someone, protecting them from danger, helping them establish appropriate boundaries, meeting emotional needs to be comforted and supported. So the whole idea of therapy, which is caring for someone, helping them not to harm themselves and not to harm others as well, and helping them to learn how to meet their own needs. Those are fundamental goals of psychotherapy.
I would like us to return to this important theme of what you call the imperative of the therapist seeking therapy himself or herself before he or she undertakes the clinical imperative of taking care of others.
Mm-hmm.
Now, it's remarkable that for you, when patients visit with you, you're not merely studying them only, although you must do that because they are coming to you for that purpose. But additionally, correct me if I'm wrong, it seems as if you're also studying yourself.
Mm-hmm.
And in that the visitation has two sides to it. Medically speaking, it's a visitation of someone who is in dire need of your expertly attention. But in a subtle, should I say, philosophical way, it's also a moment for you, as you said earlier, to examine yourself so that you can sharpen your skills. I wonder how many modern therapists, minus this philosophical temperament, which is part and parcel of your existential fabric, do that?
Well, in the therapy room, now I often work with couples, by the way. I work a lot with couples, and sometimes I'll see a family. So I might have as many as 4 or 5 people in the room. Let's take the example, which is more common, which is one individual in the room with me. There aren't just 2 individuals in that room. There is the patient with their presented self. There is their hidden self. There is their idealized self. There is their unconscious self. There is the whole baggage of their family that they're carrying around with them like a big sack very often over their shoulder. There is their husband or lover or thwarted lover. There's a lot of people there. What am I bringing? I am bringing my whole baggage, my whole background, my current relationship, my current frustrations or joys that I'm having, my current needs, possibly illnesses that I might have. So there's a very complex mix of many personas there. And so one of the challenges of being a really competent therapist is sorting out all of that, is sorting it out and keeping clear boundaries so you don't get confused. Because sometimes people will come in who have some of the same issues that you might have currently, or who are exhibiting some of the same problems that you have worked through. And there's a process in psychotherapy called transference and countertransference. Transference is when the patient, this is a very big part of psychoanalysis, transference is when the patient transfers onto you emotional reactions that they have to some significant person in their life. For instance, at my age and so on, it's easy for people to transfer onto me sort of the archetypal father figure. You know, I'm kind of calm and supposedly I have some wisdom here. And so it's easy for them to turn me into their fathers. And in psychoanalysis, you use that transference. It's a vital part of it. You foster the transference and you utilize it to help the person to work through whatever the neurosis is or the problem is. So eventually they will begin to relate to you as their father and then act out and live out the problem, but you're not really their father. So you can offer, you're the corrective father. But the therapist has a countertransference because the therapist can also see the patient as their daughter or their child. I'll give you an example. In my practice in New York, I was working with a career woman who was a lawyer and very gifted lawyer, but she was addicted to downers. And she would take depressants, and about every fifth or so session she'd call up, maybe a half hour before, and say, "Dr. Eastman, I will not be there today." So she had taken too much self-medication. But I knew that a big problem, I knew she had a very big problem with her mother. So I asked my patient if she would ask her mother to call me so her mother could come in. So her mother, who was also a high-powered businesswoman, came in, called me. I set up an appointment, and she came in, and something struck me. This was my patient's mother now. And something struck me about her, and I became progressively aware that I had this feeling of feeling small, feeling young and small, but at the same time feeling very comfortable with her. And so I had the session. I couldn't quite figure out what these feelings were. It was a good session, but we scheduled another session, which happened to be on Mother's Day. And I found myself going to the florist shop and buying a rose, a single rose, to give to this patient, to give to my patient's mother. And I bought the rose and put it in a little vase and put it on the windowsill behind some drapes. And throughout that session I was struggling. No, it's not right. It's not right. I shouldn't be giving this woman this rose. That's crossing a boundary. That's not right. But it's just like what I feel like I need to do. So we ended the session, and I was in supervision at that time. So I went to my supervisor, and I've always, for many years, I paid for private supervisors. And I went to the supervisor and I said, "Well, describe this woman." So I described her, and I said, "Oh, that was my aunt, my father's sister, one of the few people that I felt really loved me and that offered me a sanctuary from the craziness of my father's home."
Incredible. Now, George, we have about 10 minutes left, and I know And,
Well, that's an example of
absolutely.
counter-transference,
Yes,
which the
yes.
therapist has to be very alert
That's right.
to.
That's right. That's right. And now I know, George, because I've been privy to reading your potential important work on psychological disorders. You're interested in personality disorders, and I know you're working on this. Would you like, in the next 8 minutes or so, to discuss your work on personality disorders in relationship to technology? A future interview will delve much deeper into that. So I just want us to touch the surface of your work.
Yeah, personality, you can talk about schizophrenia, which is a very, very severe psychiatric personality disorder. Schizophrenia is not a personality disorder. It's a very severe disorder. You can talk about bipolar, which I mentioned
Yes.
earlier. That's another disorder, very serious disorder, and so on. There are lots of disorders, but personality disorders usually are not that severe. I mean, there are some such as an obsessive compulsive personality disorder can be quite disabling and crippling, and a schizoaffective disorder because it can involve some thought disorders and so on. So personality disorders generally are present a positive prognosis. That is, the likelihood of a positive cure or recovery is quite high for personality disorders. Although they're hard to work with because personality disorders, as the name suggests, are embedded within the personality, so that they're quite fixed and they have been around for a long time. So personality disorders may take longer than other disorders to try to overcome and treat because they are so deeply embedded and persistent ways of thinking and feeling and behaving. The one personality disorder that I'm writing about currently is called a schizoid personality. Now, this is not schizophrenic, but schizoid personality disorder. Schiz is a Greek word, and it means split. So, for example, schizophrenia is a split between the disturbed inner world of the person and the real world outside. If we can even say there is a real world, but that's a philosophical
question.
And so a schizoid personality has two worlds also, has a private, hidden, inner world, and then has an external persona. So really has two personas, a hidden, private, inner persona, and then an outer one, which kind of protects the hidden inner person. And the problem, and by the way, many schizoids are highly intelligent people and are academics. In fact, I think the academic world is sort of a breeding ground for schizoids because it rewards this rich.
Of course.
For instance, one patient that I had was a professor from a prominent university in the area who had several books written on the family. And he had the worst family life of any human being that I had encountered up to that point. So his academic persona was very successful. He knew all about, in theory, what constituted a really healthy family, but he had no capacity to produce a healthy family
himself
in his own life. So that's characteristic. So schizoids often achieve positions of power. I consider former President Richard Nixon to have been a schizoid personality. And take a person like Bernie Madoff. Either he was a schizoid personality, or he was, in fact, a psychopathic personality. And sometimes, it's hard to distinguish. But what happens is that the schizoid personality is very isolated. It's a very isolated and alone person. And I think there's a lot of loneliness. There's a book by a man named Putnam called Bowling Alone, and there's quite a few books. Are we nearing the end? Or see some?
Quite all right.
Yeah.
Quite all
There are quite a few
We have
books.
5 minutes and continue.
Okay, there are quite a few books about loneliness in our society, and I think that electronic media foster aloneness. I do not. I think maybe having different outlets on the internet, can help to connect people, but it can also give a false sense of being connected.
I cannot help but interrupt you just for a second to ask a question, namely this. I've heard you say something really insightful in one of the seminars that I attended, in which you say the economic system in which we find ourselves is so violent that it may contribute, in fact, to the flourishing of personality disorders.
Yeah. Well,
Would I be correct to ask that question?
Sure. I personally think capitalism is an economic system which is a highly competitive system that ultimately goes out and goes of hedonism, equalism, the individual's ability to wealth. The system ultimately right now.
Just think that you'd like on the behalf of psychoblem.
I'm honored that you might thought, because psychoanalysis is suffering you to rub use for this.